Now we are going to move to the third lecture, extra-articular blind collagen injection for knee pain. This lecture will be presented by Professor Dr. Leonello Milani, a specialist in osteo-arthro-myofascial pain management. He is a scientific director of Physiological Regulating Medicine. Can you start?
So I will, dear doctors, thank you for inviting me. I will speak shortly and briefly about the extra-articular blind collagen injection for knee pain. Myself and my colleagues and my doctors, we arrived to the conclusion the extra-articular compartment is as important as the intra-articular compartment. Until now, infiltrations of corticosteroids and hyaluronic acid were the top of the therapy for knee pain, without considering that knee is not only an intra-articular compartment, but for the most complete function of the lower limb is the extra-articular compartment. So collagen. Collagen was discovered in India in 1954. Here below you see the 3 books of Professor Ramachandran, who discovered himself and in Madras with his colleagues the molecule of collagen in 3 dimensions. Collagen is the most wide protein. You see that I put a dot between the word protein and tissue, because collagen is a protein, but collagen is a tissue. It has a molecular weight of 300 kilodalton, and in mammalian organism, it is the 5–6% of an adult body weight. 1/3 or 1/4 of the whole protein mass of higher animal, and of course man included, is composed of collagen. We have never to forget that bones, tendons, joint capsules, muscles, ligaments, serous membranes, teeth, skin, and the extracellular matrix is collagen. Not only collagen, of course, but the main component is collagen. The collagen biosynthesis peaks between 40 and 60 years of age. That is to say that in the 6th decade of life, collagen diminishes rapidly, together with the synthesis of elastin and the matrix proteoglycans. Practically, the total collagen pool is halved between 60 and 80 years of age. Here we can see very well what it happens about the 3 main substances that form the matrix of the connective tissues. That is to say, in green, the collagen, in blue, the proteoglycans, and in red, the elastin. As you can easily see, the peak of elastin is at the 15 years of age. The peak of the proteoglycans practically is ending at the birth and then decreases during life. Meanwhile, collagen, it increases in biosynthesis until 40, 45. Then we have a plateau from 45 to 60. Then we have a breakdown of collagen from 60 and over. So the problem of the senior people is, among others, chronic inflammation and collagen deficit biosynthesis. As all the biological substances and molecules, we have 2 kinds of enzymes that make a degradation of collagen. Those are called the matrix metalloproteinases, that it is a peptidase, MMPs, metalloproteinases, that prevail on the tissue inhibitors of the metalloproteinases. They are called TIMPs. So for making collagen, we need MMPs. To produce collagen, we need TIMPs. To degrade collagen, we need MMPs. But how do they act? The TIMPs in reality are the natural inhibitors of the MMPs and the disintegrino metalloproteinases that play an important role, and the TIMPs that are the anti-collagen MMPs practically are encoded by an allocated gene on the X chromosome. So this is one theory that says intelligent, Aviv and al. In 2005, they suggested that being allocated on the X chromosome, this partly explains the greater longevity of females that have two allosomes XX versus male. But we have adrenocorticotropic hormone, interleukin 10 and interleukin 6 that stimulate TIMP1 through the inhibition of the MMPs. This will explain better. So for the degradation of collagen, we need MMPs. And this degradation, as you can see, is enhanced also, boosted also by, in red, interleukin 1, interleukin 6, tumor necrosis factor alpha, and ROS. So it means that the degradation of collagen begins naturally because it must be replaced. But when we have locally or chronic low-grade inflammation, also because in acute and in chronic low-grade inflammation, we have interleukin 1, tumor necrosis factor alpha, and ROS that control the degradation of the collagen. For the new synthesis, of the contrary, we have the TIMPs, as we saw before, but the anti-inflammatory cytokines that are well known as to be interleukin 4, interleukin 10, interleukin 6. Also 6 you see in red on the right and in blue on the left, because they play different roles depending on the milieu and the trophic growth factor beta 1. So if we have biosynthesis and degradation physiologically, we have a good performance in our collagen structure. If one goes up and the other, of course, on the contrary, goes down, we have or an hypersynthesis, as in the case of the wound healing, for instance, with the cicatrices, or the degradation, as we have in many osteo-arthro-myofascial pain disorders. This is the structure of the collagen. It is a triple helix made by alpha chains. They are very tight because the hydrogen bonds and the van der Waals forces tie together these three alpha chains. On the right, you see the good collagen with the typical bands in brown. Meanwhile, you see the typical bands of collagen in the spot in gray, black and white. As you can see easily how it is done. Practically, we know now that the single tropocollagen fibers slide of 1/4 on the lower fiber in relation to the upper fiber. So after 4 consecutive skiddings, the 5th fibril is aligned to the first. And in this case, we have an elasticity and anisotropy that are characteristics of collagen, and strength. So now let's speak about the extra-articular compartment. The extra-articular compartment of the knee, of every joint, but especially of the knee, as we shall see later, is formed especially by the synovial membrane, the articular capsule that join together 2 contiguous bone, the extra-articular ligaments that are extremely important for the stabilization of a knee, for instance, and the muscle tendons. And between the extra-articular ligaments and the muscle tendons, we have the great anatomical capsule that puts together the two bones, in this case, femur and tibia and fibula. What happens when collagen is injured? You see easily at your left, you see normal collagen fibers. On your right, you see what happens when collagen fibers are disrupted. In this case, we find that even a torsion or a stretching of a capsule can produce histological changing very ready and very hard, very strong. What about human knee? Not so many experts in orthopedics know what it is the Q angle. Practically, the Q angle is the angle that is formed if we trace a line from the anterior superior iliac spina to the center of the patella. This is the first line. Then, from the center to the patella, if we draw a straight line, we form a Q angle. In males, normally, the Q angle is 13 degrees. Meanwhile, in females is 16 degrees. This is why females suffer more than males of knee problems, simply because having a larger pelvis, these angles, this Q angle is higher. But this is, by the point of view of the orthopedic philosophy, a sort of handicap, and we shall see why and what is the reason why we have so many problems. In the center, you see a normal knee with the femur, patella, and tibia and fibula in a normal position. But in genu varum, as you can see easily, you see that for maintaining the stability, the superior part, the articular part of the tibia, has to go out. And this produces the genu varum. The contrary is for the genu valgum. In fact, the valgus knee involves external hyperloads. The varus knee involves internal hyperloads. But these two bones, practically, they can move a part of the internal cruciate, anterior and posterior internal ligaments, by the extra-articular compartment. In this case, for instance, as I heard before by a colleague, the majority of the problem appear in the internal part. Here we are in a three-grade Kaiser-Lorentz radiologic scale. You see that if we imagine the capsule, the ligaments, and all the extra-articular part in the right side of the slide, this is practically abundant, while it is stretched on the other side. It means that it shrinks where the yellow circle is pointed, and it is stretched outside. We do not think so much about these movements, but these movements happen physiologically every step we do every day. So the extra-articular blind collagen injection for knee pain. On the right, you see a right knee with a drawing of the patella and some points drawing where these points are put. The red arrow, that is to say on the left, the red point, is the insertion tendon of rectus femoralis muscle. On the contrary, we have the patellar ligament in blue, and the arrow points the maximum, the best point of injection. And laterally, we have the transversal lateral and medial retinaculum of patella. So these 4 points can be useful injected for keeping the extra-articular compartment of the knee in the best position possible and reducing pain. This is anterior. What about for the internal collateral ligament? Always the right knee, the patella is up. You see the drawing where the skin drawing with the point yellow arrows are. They are exactly at the beginning and the ending of the collateral internal ligament. Why the beginning and the ending? Because they attach as all the ligaments, and the movement of torsion that we do in every step of our walking, progression, flexion, extension, torsion, internal and external, microtrauma continuously, they have no protection. They have no patella. They have no strong muscles that pass in this part. So they keep of the load of the partial torsion. This is for the internal view. And this is for the external view. The same for the external collateral ligament. By an anatomopathological reports, these 2 points, as the other ones, as we saw before, are not perfectly attached to the bone, but practically they are spread. They are full of fat. In some way, they are the points where the ligament has the maximum of the possibility. Ligament equal collagen. Collagen goes down after 45, 60. Senior problems of the knee. osteoarthrosis, for instance. And this is the ninth and last point. Practically is posterior. It is in the popliteal fossa. And you see how the ligaments play a key role. The surgeon that are hearing me know very well how it is difficult to approach the intra-articular part by surgery, because they have to cut open all these structures that are very strong and very tight normally, but they are not so strong and not so tight when there are disalignment between the femur and the tibia. They move in this way. So in one part, it is stretched, the capsule and the ligament, and in the other part, it is more abundant. But these structures are collagen made. So what we can do and can propose for strengthening, making stronger the capsule and all those ligaments in these 9 points that I have shown you. The last is to see how many extra-articular parts are. I pointed out the green arrow and the red arrow where there are parts of the capsule, but the capsule practically englobes all the knee. I have told you before that collagen has anisotropy characteristics, so it works well depending on the specific line. But if these lines of movement, if these lines are disrupted, practically the two bones move. Of course, they don't move of centimeters. They can move in centimeters, but even millimeters, and even with varus valgus or the defects of the Q angle, produce an over internal or external load. That's why the sufferance of the osteoarthrosis appears. So for the solution, I suggest you what it has been used since 6-8 years, I would say all over the world, because the medical device, MD is medical device, knee, which is done with collagen type 1, of course, must be type 1, plus an auxiliary substance that in case of MD knee is arnica with ellenaline, with great anti-inflammatory activity. 2 vials that are 4 milliliters distributed in these 9 knee extra-articular points, as I have showed you before in the previous slides. In each point, injection of 0.405 milliliters of MD knee. So week 1, 2 treatments in 1 week. Example, Monday and Thursday. Week 2, 2 treatments, same days. From week 3 to week 8, can be also week 6, can be also week 5, can also week 10, is depending on the gravity of the pathology, of course. 1 treatment per week. Normally, the treatments are 2 the first week, 2 the second week. These are fixed treatments, and 1 treatment per week for other 5-6 weeks. After 6 months from the end of the last treatment, you repeat only 2 treatments in 1 week, and that's all. Every 6, 8, 9 months, 1 year. People don't come back. They are without pain, or in case they are waiting for surgery. This can be done for osteoarthrosis or osteoarthritis, but even in sport medicine, as we have experienced in football, that have many problems of the knee. So this is not echo-guided, this is a blind treatment. Why? Because the needle is 30 G, long 1.5 centimeters. You then don't have to inject, use all the 1.5 centimeters. You can also use 1 centimeter. It's depending on how big is the knee, the quantity of fat, and many. With very thin needles, they are 30 G, there is no risk of hematoma, there is no risk of touching some important parts that can or may be dangerous, as for instance, posteriorly, the last point, as I showed you, in the popliteal fossa, there is the great ischiatic nerve that passes, or internally, where there is the collateral intern ligament, also the problem of touching the safena magna. So there are not no risk at all. In case we can aspirate a little bit, but there is no risk, and it is very, very effective treatment because we are treating the extra-articular part. This does not mean that the same patient can have also hyaluronic acid, but we never, not corticosteroids, please, anymore, into the knee, because corticosteroids, cortisone eats the cartilage. One injection of depomedrol can be sufficient for the doctor purpose, but maybe not sufficient for the patient. So continuously giving corticoids into the knee is a mistake that all orthopedics all over the world from the last 40 years did. Hyaluronic acid is a viscous supplementation, does not change the physiology or the normal mechanical physiopathology of the knee. It is just like a drop of oil in an engine. Of course, it goes better. It goes better, yes. But if the engine is damaged, practically after 2 weeks, it must be repeated. That is why treating the extra-articular part is always a good idea. We have now experience, as I told you, in 30 different countries all over the world using these techniques. They are super granted because the experience is now of 8 years. The medical device knee is approved, of course, by the Superior Institute of Health, and in Europe and in many other countries, of course, of the world. So no risk at all. No risk at all. The last slide is, but why does work so well collagen for replacing and for stimulating the neosynthesis of the physiological collagen? This has been a work published by doctors from the first orthopedic clinic and the orthopedic specialistic center Gaetano Pini in Milano and the Department of Biomedical Science of Health. This was published in Cells in 2020. I remember you that Cells has a very high impact factor of 6.6. What did they do? They took some fibroblasts were obtained from an healthy tendon of gluteus minor muscle. So from the healthy tendon of a muscle, gluteus minor muscle in this case, was taken apart and taking the cellular fibroblast cultures, they covered with GUNA collagen. So 2 Petri capsules, one with agar-agar and fibroblast, healthy fibroblast. They grow, of course, because of agar-agar. The other capsule is agar-agar, fibroblasts of the same origin, and GUNA collagen. The conclusions of the authors is, in particular, we demonstrated that GUNA collagen influences the fibroblasts involved in the extracellular matrix composition and improves their capacity of migration in confront of the other group, of course. We confirm that GUNA collagen, acting as a mechanical support, is a medical device for a new regenerative and rehabilitative approach. For further information, we can ask for a brochure. All published articles on medical device, more than 45 in peer-reviewed magazines, of course, the news, what's happened, and the media events with this collagenmdguna.com. So this is the mosque and Madrasa Sultan Assam in Cairo on your right, and the Dome of Milan of your left. I hope that this new collaboration and friendship, not only between the two countries, but also between the doctors of the two countries. Shukran. Thank you very much for your kind attention.
Thank you, Dr. Milani, for this nice presentation and the provision of a new and safe method for management of knee pain. You have several questions here. The first is, does the site of injection will differ if the deformity is valgus or varus?
The sites of injections that I point here are normally anatomically been anatomically studied. They are the most important points because here you find the A delta and C fibers, nerve fibers, A delta and C fibers. A delta is the smallest of the myelin fibers. The C fiber are amyelin. So A delta and C fibers stimulated together by the needle and by the liquid of the MD produce also a neuroreflexic effect. But normally, you can see it very easily from tomorrow if you want. If you touch in a knee problem those 9 points, you will find them with your finger always active, that is to say painful. Or of 9 you can find 6 or 7, but 9 must be infiltrated because they cover the complexity of the knee joint.
Another question, what about the depth of the needle?
The depth of the needle is depending on the type of patients, of course, because we have fatty patients, especially females, or very skinny patients. Now, you find problems of the knee of two kind of patients, as I used to say with my assistants, the fat woman and the skinny man. Curiously, but it is so. Yes. So it's depending on the anyway, you enter maximum 1 centimeter, or in skinny people, also half a centimeter, until you touch the end of the tendon. You find it easily because at a point the needle doesn't go deeper.
Thank you, Dr. Milani, again.